Well, as you can see, we're here at Aberdeen Airport, anticipating attending what looks to be an extremely interesting and varied programme at Southampton, where we hope to speak to several of the international authorities who are chairing and speaking at the meeting. My good sir.
Well, I wouldn't say necessarily that it's safe to go ahead and use dopexamine routinely in every patient, but what our results suggest is that patients undergoing cardiac surgery do show this high lactic acidosis level, and that they do need their cardiac output augmented. Now, whether or not they need dopexamine or they need something else still isn't clear, but our results suggest that they are doing better on dopexamine than just being left alone.
A lot of emphasis has been placed recently on the question of increasing the oxygen delivery to the tissues. Now, you measure this using a thermodilation pulmonary artery catheter, measuring the cardiac output and the oxygen content from an arterial line. When you actually get the figure at the end of the day, what does that tell you about the oxygen delivery to individual tissue beds, for example, to the kidney, to the brain, to the gut? Can you reliably use that figure?
Not really, no. We don't have access to this information, but the point is to know whether we really need this information. I mean, it would be nice. It would be nice to know exactly how much blood and how much oxygen is going to the various parts of the body. But is it essential? I'm not sure of that. We would like rather to have a global information about the entire body. We would like to know whether the cells in general are happy or if they are still hypoxic. Right. If you could, during an acute circulatory failure, if you could really redistribute blood from one organ to the other, how would you do that? We have said this afternoon we might shut down the muscular bed. I'm not sure it's the right thing to do, because the muscle can produce a lot of metabolites, including lactates. You know. Yeah. If you shut down the muscular bed, you might go down with very low pHs, very high lactate levels. You might depress your myocardium, and you might go into a lot of trouble. I think that the organism already is trying to do its best to maintain organ blood flow, I mean, relatively optimally. Maybe the kidney, indeed, in this particular game is a little in a disadvantageous position. But otherwise, I'm not sure that we can do so much about the distribution of blood flow in the organism.
Have you anything to add, Dr. Edwards?
No, I just agree that it would be very nice to know what the regional distribution was, but at the moment it's not practical. But we have the evidence is not conclusive, but it's very strongly suggestive that even though we can't measure the regional blood flow, that maintaining high levels might improve survival. Right. It's circumstantial, but it's very strong. And the other thing, on the negative side, we know that if you measure oxygen transport, that a lot of the things that we routinely do to patients, as we've heard about vasopressors, or sometimes fluids or mechanical ventilation, a lot of those things that we take as routine therapeutic procedures, they actually lower global oxygen transport. Okay. And unless you're measuring it, you don't know that you're doing that.
This morning we heard about some of the mediators of the multiple organ failure or shock state, and it seems to me that intensive care now is moving towards a cellular level rather than what we've talked about just now. Is there any therapeutic implications for this research? What we're going to do with knowing about these mediators? Can we do anything, or is it trying to just knowing about something that happens before in the patients that we're trying to pick up the pieces with afterwards?
I think we'll do a lot. That will open an entire new window with a lot of therapeutic implications. There are 2 studies now submitted to the New England Journal of Medicine showing in a prospective fashion that endotoxin antibodies improve survival from septic shock, because both studies are positive. And that's really something very, very impressive and very encouraging. I think we will be able to interfere with those mediators. We are presently looking at the effects of anti-TNF antibodies in septic shock patients in our unit. We have treated 7 patients already in a prospective controlled fashion, and I think in the future we'll use this kind of cocktails, you know, with anti-endotoxin, anti-TNF, anti-PAF, maybe anti-platelet activating factor, maybe some cyclooxygenase inhibitors. In 10 years from now, I'm almost sure that we will have some kind of cocktail that will administer as soon as possible in the septic shock patient in particular, and that will improve survival. I think it's very, very interesting.
Yesterday you gave us a very good outline of the degree of underrating gastrointestinal failure in intensive care patients, and you mentioned some good guys in your story, namely good resuscitation, oxygen delivery, and sucralfate you mentioned. Now, not everyone in this country is familiar with sucralfate, and we tend to use H2 antagonists. Could you briefly tell us the benefits that this agent has over the standard H2 antagonists?
Right, well, the main problem with both H2 receptor antagonists and antacids is that you're neutralizing the gastric acid content. As soon as you do that, then you get a change in the bacterial flora within the stomach and potentially further down the gut. What has been shown in a number of studies is that you get overgrowth of potentially pathogenic gram-negative bacteria, and these regurgitate up the esophagus and into the lungs, and there have been again a number of studies showing a high concordance between the bacteria that you can get from the stomach and the bacteria causing nosocomial pneumonia. And this indeed was one of the stimuli that led to the development of the selective digestive tract decontamination regimens. The advantage of sucralfate is that in a number of controlled trials it appears to be equally efficacious as either H2 receptor antagonists or antacids. But doesn't neutralize the gastric acid content, so that the normal gastric flora is preserved. You don't get overgrowth of those potentially pathogenic gram-negative organisms, and you have a lower frequency of nosocomial pneumonias. And this was well illustrated in a study reported by Drix and others in the New England Journal of Medicine in 1987, and another study by Triber and others reported in the American Journal of Medicine also in 1987.